remember, the body is actually pretty smart. And if we can kind of let the body do its job with a little bit of help, we're going to be better off than if we try and interfere too much. So there's a lot of information out there. You have to be able to learn and understand and figure out what's good information, what's bad information. But I really encourage you guys to keep learning. I love educators like Ezra out there doing this. Try and educate yourself as much as you can, because you're not going to rely on the practitioners to do it. And, you know, a lot of the people who are out there preaching things have something to sell, right? So you have to be careful.
I'm Dr. Esra Çavuşoğlu, and I've been living a sober life for the past 18 years. My battle with addiction drove me to seek new methods, devices, and supplements to improve my physical and mental performance, enhance my quality of life, and ultimately live healthier for longer. From my experiences in addiction recovery, biohacking, and longevity to the latest global developments, from groundbreaking entrepreneurs to expert academics, the conversations I've had over the years are now featured weekly on Soberhead Podcast. Welcome to this special episode of Soberhead Podcast with Dr. Elizabeth Yurth, whom I'm currently working as my doctor. She is hailed as one of the greatest minds in regenerative medicine. We dive into Biohacker Syndrome and why more supplements aren't always better, plus game-changing therapies like GLP-1 Agonists, Rapamycin, and other second-purpose drugs. She reveals the crucial link between bone health, muscle strength, and true longevity. She busts myths on topics like cholesterol, NAD, and telomerase. If you're ready for practical science-based insight on living not just longer but better, this conversation is for you. Now, let's go to the episode. Here is something that is fascinating. A huge amount of people who watch this channel frequently are not subscribed. So I want to ask you a quick favor. When you subscribe, it helps us to make the show better, access to the world-leading experts, and ultimately bring you more value. All that I ask is for you to hit the subscribe button, and in return, I promise we will make Ayık Kafa better every day. Well, my dear Dr. Elizabeth Yurth, welcome to Soberhead Podcast.
Thank you, Ezra. I'm honored to be here talking to you.
Actually, I'm honored to be your patient, and let me give a little bit of an explanation who you are for me, then I will ask actually how you got involved into this progressive regenerative medicine. You are called in the field the greatest mind in the regenerative medicine, the GOAT. And my journey started after pursuing you very intensively from all type of channels, Instagram, emails, whatnot. Putting people in between. Finally, you accepted me as a client, which is wonderful. Therefore, for the last 6 months, I got a chance to see how your mind is working. And the reason actually I decided to do that, and I hope that many people who will watch this podcast will benefit from my own experience, like negative experience, let's put it that way, not with you, in general. I'm a person who gets very excited when I see something new is coming up. Supplements, interventions, machines, name it. It's like a funny, weird thing. It's like a hobby. It's like, oh, there's this supplement. Oh, let me buy it. And you keep listening to the podcast. There are more. At some point, I'm like, I need someone really to guide me what to take, what not to take. Obviously, you scratched half of it. I'm not taking most of them anymore, and probably my mom who's going to listen to this is like going to be like, oh, I told her so many times and she didn't listen to me. But I also saw that you are changing stuff. And even in a couple of podcasts, you said like things that I'm going to be okay today, I may change next year. So with that start, who are you? Why are you so great? I mean, I know you're great, so it's hard for you to probably say. I know that you are involved in researches as well as you have a clinic.
Right. So I call your syndrome, Ezra, the biohacker syndrome, because we see this all the time with these biohacker people who come in literally with 15 pages of supplements sometimes, right? And it's hard because we sit there and we listen to, we read and we listen to all these things. And it's like, oh my God, that's great. Oh my God, that's great. And so we just keep just adding to this list. And remember, the body is actually pretty smart. And if we can kind of let the body do its job with a little bit of help, we're going to be better off than if we try and interfere too much. So, I think, one of the things I've learned through the years is sometimes less is a little bit more. That we need some basics we need to cycle things through, but we don't need to be on a billion things. If I look back at if you look at like your mom or like my parents lived into their 90s, and and pretty healthily into their 90s until the very end, really. But they weren't taking 10 billion supplements. They ate super healthy. They, exercised every day. They slept well. They had, they monitored stress pretty well. It was an easier time, obviously, that, they didn't have all the exposures that we do. So obviously we're in a little more difficult time with a lot more stress and a lot more environmental exposures and bad things like that. But about myself, I got into this field in a little bit of a roundabout way from orthopedics. So the orthopedic world is not really geared at all to longevity medicine. In fact, our goal is to just kind of patch people back together and then replace a joint. So I got really almost 20 years ago now, I started to get really frustrated. I've been doing orthopedics a long time and felt I was just sort of patching people back together and then sending them back and they'd hurt themselves again and nothing really ever got better. So I started to actually explore how nutrition and hormones and supplements could actually help people to heal. So I went back and retrained in longevity, regenerative medicine, got a few more degrees, and then did both. Did orthopedics by day and regenerative medicine by night. And then finally really merged them together into one practice where we do a lot of regenerative orthopedics still, but we really try and make people healthy because that's really how people heal. So I got into this world a long time ago when it was sort of early on, when these conferences were 500 people, not 5,000 people. And when our knowledge base was pretty limited in how much it is, to watch the field grow the way it has been remarkable. And now people, are really jumping on these bandwagons, and you've got people like Brian Johnson and people like that who are just, all in and pushing all these agendas. And I think we still have to go back to sometimes some of the simple thinking of, what are the basic things we need? These fun, shiny things are great to go after, but let's still kind of keep a sensible level of what health is. I think that my goal always is to be on top of the most leading, cutting edge stuff by working with the researchers in the field. I work with a lot of people who are in research. We're doing some research ourselves. We have a longevity docs group that we're doing some research together, just gathering data from our own patients and putting it together with things like how the GLP-1 agonists are working or how different modalities are helping so we can put data together. So we're doing that, but always keeping a focus on what are the basics that we need to do and what true bright, shiny objects should we be targeting.
With that said, where do you get your information? Because if you just suddenly decide, hey, this is not working, so where does this come from? Because the messages is always the same. What we hear is always the same. What I heard from you is not the same.
Right. I do think you really have to keep an eye on the researchers, right? And mostly the researchers who are not in it for an agenda, which is hard to find, right? If you look at a lot of research, it's trying to promote something. It's somebody who has an investment in a supplement, and so they're researching that supplement. So you have to find the research that truly is cutting edge, but doesn't have any type of financial incentive to be doing the research. A lot of that comes from other countries. So a lot of that comes from China, Asia, where there's a little bit less of the financial incentives involved. So you have to kind of go to a lot of that. So you have to be really deep diving the research every day. And so I have, every single day I set aside about 2 hours at the end of my day where I look for what are the newest articles that have come out, and that are coming out that day, or maybe even pre-publications. And there's ways to, access even some of the pre-publications through some of the now things you can get online. So, I'll go to Nature Aging Journal, Cell Journal, Journal of Gerontology, but really where people are doing this research straight on. Then you look at the research and then you pick apart the research and you say, is this actually truly good research? Is it not good research? How can we adapt that into what we're doing with our patients? And so that's really where I'm going every single day to try and get my updated information. And then a lot of it's too just conversations. The fortunate thing is we have this group that we WhatsApp chat 50 times a day of longevity docs from across the world, and seeing what everybody else is doing and what's working for other people is really helpful.
It's interesting because I can only imagine that you also get excited when there's a new supplements coming out, like
I do.
Fisetin or C15? No, Fatty 15.
Fatty 15.
Yeah,
right.
So I see that you get excited, but then you're like,
wow,
it's not working that great, and you pull it back.
Exactly. I mean, I think that there's things that you look at the research, it does look great, right? You're looking at, okay, this makes sense. It does look great. And then we have the opportunity to start putting it into practice. So we can put it into practice for a while. We can start watching labs. We can start, watching, our patients. And that's where being able to put together, it's kind of like having a lot of N of one data. We have 250 physicians now in our group network. So everybody can say, what are you seeing with this? And when enough of us are not seeing the results, or when even in my own patient population, I'm seeing everybody on this supplement, now their labs are starting to look worse than what I was doing with them before. Then I know that maybe I need to relook at that. I need to change my mind. I need to readdress. I need to go back and look at the data. Is it still supported? Was I maybe fooled by the data the first time? So I think that's the biggest thing in this field, Ezra, is you so have to stay open-minded that maybe what I thought was going to work isn't as good as we thought, and be able to change your mind and move forward.
I think that is very difficult for most doctors because, they've been prescribing, let's say, whether hormone replacement therapy or anything else that, they've been doing it for 15 years. It's very difficult for them to change. Not because they don't want to change. Probably they don't want people to think that, oh, you know what, they were wrong.
Right. I mean, I tell my patients all the time, I said, yeah, I know, I thought that was the right way, but it's not panning out. And so I do think we have to be able to admit that we were wrong. We have to be able to admit that we need to move forward and do something different. Doctors are the worst about that, I think. And they really are. I mean, it's the hardest thing is trying to change a doctor's mind to something, because you spent a lot of years educating yourself a certain way, and to now look back and say, what I was doing was wrong. And so we're seeing, the doctors who have gotten now into cellular medicine or functional medicine maybe are a little bit more open-minded, but I'm seeing the same trends. Now they get really set in their ways. This is the way I'm going to do things. And, if you're preaching over and over again that, that this value is the right value, and 10 years later, it's turned out not, you have to be able to say to your patients, I was wrong.
With that said, Dr. Yurth, where is this whole trend going? I want to merge two of the questions that I sent you. One is like, where is longevity medicine going? And are we going to be living until 150? With that said, I want to add a little note, because I was thinking driving to the studio. I called my mom, actually. And I said, you know what, Mom, I received this whole 50-page of a document, and I actually sent her because she's very interested into them. But I think there was a paragraph over there really caught my attention. It's not how long or how healthy you live, but it's very important if you're enjoying life while in these years of healthy living. And then I thought of my aunt. And in a couple of other podcasts, I mentioned how she approached. She has certain illnesses, like she has diabetes, she has hip replacement, and some other stuff. Therefore, her life quality is not that great. Yet one day we had a dinner around the table, and I was talking about the EMF radiation, this, that, and the other. You need to eat clean, all this whole thing. And then she turned to me and she said well, you know what? Sitting around this table as a family gives me incredible joy. What you wrote there as a paragraph and what she said suddenly made even a better sense. She didn't care her illnesses because she has a purpose. She has a nonprofit organization. Right. She enjoys family. So I just had to add that.
I love that, because, we always have gotten into this, okay, well, it's not lifespan, right? It's health span. And then when you get to thinking about it, well, can you actually maybe not, like your aunt, maybe you don't have all these, perfect health, right? But I love my life. I love what I'm doing. I can do the things I want to do. I mean, people are, if the only thing that makes you happy is running a marathon and you can't run a marathon anymore, then maybe you don't want to be alive. But for most people, our goals change, right? That's just part of living, is that my same goals. I don't need to be able to run a marathon the way I did when I was 25. I need to be able to do other things better, right? And I love Dr. Goodenow always talks about this, where, if you're not changing, you don't want to be the same person you were at 25. You want to be a different person. Neither do you want your cells to be the same person they were at 25. You want them to have changed. You want them to have learned. So when we're chasing these numbers that would say, okay, I want everything to be like I was when I was 25, is that truly what we want? It might not be. It might be that there is a goal to to longevity that is much more adaptability, right? That we adapt to the changes that are occurring within our body successfully so I can still accomplish the things I want to do at that time in my life. And so I love that because, if you are still enjoying life, even if you truly do have some health challenges, then there's a reason to continue, and we can control those health challenges, right? We adapt to the health challenges. So instead of saying this how long we are free of disease, let's say how long are we adaptable enough to still be able to live the life I want to live, to make myself happy. So I think we need to change our thought of longevity into kind of adaptability, right? That we can adapt to changes that are occurring in our body, that we can keep our body moving forward and pliable to adjust to anything that happens. So that even if my health is not perfect, I've adapted to that and I'm still fine. So I think that I love what your aunt is saying, and I love that thought of that, because I think we really do need to change this a little bit. Like, okay, everybody needs to never be free of disease. We might not accomplish that purpose, but can we make the cells adaptable with that disease so that we can still be able to do the things we want to do? So I think that when we look at all the cool things that are happening in longevity, it's fascinating. There's, when you look at things like Yamanaka factors, and with AI, we're going to be better and better at that. We're going to be able to pick out these factors that are truly, life-changing molecules that we can do. So if we look at, 2006 is when Yamanaka discovered those 4 master switches to the body. 2006. It's a long time ago, right? So we look at 2006, we're already finding these things that and for those of you who don't know what Yamanaka factors are, there's really these 4 factors that are kind of like a code. So if you put these 4 factors in, it's like hitting a reset button on a computer. And if you use these 4 factors, you could retrain cells, right? So you could sort of bring back a stem cell. And the key was that we thought that it would be, this perfect thing that we could just sort of reset everything back to what it was when we were young. And then we realized we actually didn't want that. We didn't really want everything reset back to where I was young. It's kind of like if I trained my whole life to be an accountant and now somebody reset it and I no longer knew accountant, that would be a bad thing, right? So the Yamanaka factors became a little bit more tricky to utilize because we realized we don't want our cells to all just be reset. We want them to be changed but not reset, right? So that's where the tricky thing comes in some of these senolytic therapies. It's also really complex, and that's what we're learning. It's not going to be one magic drug. It's not going to be one magic treatment. We're going to have to address this from a whole lot of aspects, and addressing senolytic cells, addressing our immune system, addressing how mitochondria change with age. So I think that that's going to be the key, is being able to put all these things together. And that's where AI is going to really help us, right? Because we can put so much data together and say, okay, I have all these things. What is going to be the best things? So I think that let's start, number one, let's start sort of rethinking what immortality is. So to like a functional immortality, meaning our ability to be able to adapt to anything that is thrown at us, not prevent anything that is thrown at us, but adapt to anything that's thrown at us. So I think that if we do that, can we live to be 150? At some point, our organs start to fail. We're going to have to be able to actually regenerate organs, but probably we can do pretty well into 120 if we can adapt to these changes. Instead of resisting the changes, teach our body how to adapt to the changes. So
organ by organ, cell by cell, it seems like what you're saying.
I would say really it's at a cellular level. We have to have our cells adaptable to what the next thing, when the next challenge is going to be exposed to them.
Then with that said, let's jump into this biological age stuff. I got so disappointed back then when I was testing, but I mean, is it possible? Is it possible to reverse that much? Is it possible, because everyone, every podcaster who does follow a longevity thing, I don't want to name because you're a known doctor. I'm sure you don't want to be thrown into these conversations, but every single person who is known, whether doctors or biohackers or podcasters, for some reason they're over 60, but they're all 35 years old. I mean, and I am still my age, so I don't understand.
In theory, the biologic age testing sounds great, right? If we can truly tell you what your biologic age is, I don't think we're there. Number one, if you look at what most biologic age theory tests right now that we have are utilizing something called the elastic regression theory of aging. And that suggests that aging markers could be perfectly regressed to predict age. And that's really been actually debunked. The first test that actually is not utilized is one called Generations Lab. So they've actually no longer used this sort of linear thought of aging, because aging does not follow this linear pattern. Different tissues age at different rates. So I think number one, our tests were not great. They were also not very reproducible. When I look at biologic age testing, I had a patient who had a lot of money who actually did a biologic age test every day for a week. There was 10 to 15 years difference throughout the week about what is biologic age tests. So most of them have DNA methylation clocks, and they just can't reliably distinguish things. For instance, if something's creating a little inflammation that day, it's going to be marked and potentially show up. So and I know I'm controversial on this. I think biologic age testing has a long way to go before people should be depending on that as the gold standard for saying something is working or something is not working. And I also really like, this is another place where, should our cells look the same? If we know what a methylation markers look like when I'm 20, and now I say that's my gold standard, should my methylation markers look the same? Because Dr. Goodnow has some very good evidence, and he studies a lot of metabolomics on this, some very good evidence that they should not.
Why not? Why not?
Because our body has to learn to adapt to things that it's been exposed to, right? To things that are happening to you. If my cells look the same, it would be like saying to you, do you want to be the same person you were at 18, right? You don't.
Definitely not. Definitely not. I don't.
You've learned a lot. That experience is huge. Well, that's true in our cells too. So are these methylation markers on our cells that are occurring with age actually somewhat of a good thing? Certainly some of them are going to be, right? So I'm not sure that we have a great answer on these clocks. Number one, the elastic regression theory of aging, which is what most of the clocks are based on, has been disproven. Newer clocks maybe fixing that a little bit. But number two, I don't know if we truly know what a healthy age looks like. So I think we should use them judiciously. I do think I can get some value out of looking at, for instance, Generations Lab gives me sort of what's called biologic noise from organ systems. So I can say, oh, look, the immune system is failing faster than the gut. So I can point myself a direction, but not give me a perfect little age of things. And I think to depend on that is silly. I think that we right now we don't have standardization, we don't have reproducibility, we don't even know what our clocks mean, and that we're doing these, aging Olympics, and people are putting all this money, into, oh, look, I'm 30 versus 60. I don't think that we have any idea what we're looking at, honestly.
It sounds like a clickbait, because all these people who says that are pretty intelligent. Most of them actually have access to you. And I'm sure you're training and teaching them, not only treating them. So this is like kind of conversation out to public. Hey, I'm this age, that age.
Right.
With that, there are also a bazillion myths. Someone comes up with a supplement that everything is going to be cured with, and then tons of supplements, no inflammation. So, what are these myths? Telomeres, that was a big one at some point.
Yeah, I think there is a ton that we don't know right now that we're sort of...
Let's put it this way. Actually, let me rephrase the question. What would be your message to people who listen to that? Because people are getting very confused.
So number one, there is not going to be one magical thing that we can do. It's not going to be the answer to longevity, or rapamycin is the answer to longevity. There is not going to be one magic tool that we can, or even two or three, right? We're not going to do it. So if you're depending on that, okay, rapamycin is going to be the answer, or dasatinib and quercetin are going to be the answer, that's foolish. Aging is too complex to have one system. Even if that drug is affecting multi-systems, it's just too complex. So we need to get that out of our head. If we're addressing aging, it's going to have to be from a lot of different realms, attacking it from a lot of different ways. Number two, I think that I think that's the biggest myth is everybody is really looking for that drug, right? That magical drug that's going to be, and I think all these things are helpful and contribute, and I do use them in my practice. I use rapamycin, I use these things, but it's foolish to think that there's going to be one thing out there. So those people who are really looking for the magical drug or the magical cure, that's too simplistic. Number two, it's that whole more is better, right? That thing that you talked about falling into, in debate with is that, that, oh gosh, antioxidants are really good. So I'm just going to take tons of antioxidants because then I will have no oxidative stress and that'll be great and my longevity will look great. No, everything is a really delicate balance. And when we start thinking that way, like antioxidants are good and oxidative stress is bad, oxidative stress is not bad. We need oxidative stress. Right? If we didn't have oxidative stress, we wouldn't build muscles. We wouldn't mount an immune response. So we need oxidative stress. So we've got to use antioxidants judiciously, just like we do other things. We bring them in and out. We don't take high doses of them. We don't do them continuously. We don't take 15 different antioxidants. Otherwise, I blocked all my oxidative stress, and that's a bad thing. So I think that's really, and that's the biggest thing I think I see people falling into. I see people who are taking 15 different antioxidants on a regular basis all the time, and they're doing themselves harm because now you've actually blocked all oxidative stress and you err to the side of reductive stress, and that's going to lead to things like cancer.
Can you know that without can you see that on a blood marker, or if it's anecdotal that they say I take this, that, and the other, and you say that's bad?
So it's a little hard. You can measure things like superoxide dismutase, glutathione peroxidase. So you can look at some of these markers. I think one of the best markers to look at is what's called 8-hydroxy-2-deoxyguanosine, which is an oxidative stress marker. And if that's either too high, means you do have too much oxidative stress, or too low, you may be blocking oxidative stress. But I don't know that I think, again, it's going to be a little bit of a understanding that this is just the way the cell works. And I don't think you need to do fancy tests. You need to balance things and use them in a conservative fashion. And my bias is you're always going to be best by cycling on and off of these things. Because by giving your body time on, time off, it allows that adaptability that we're talking about. It allows the body to stay sort of aware and doing things on its own instead of just dumping things in the system that may be destroying it. So I think that yes, there are some tests that are helpful. So they will guide us a little bit. When I can see markers of oxidative stress, it's measuring too high oxidative stress is easier. Measuring too little oxidative stress is a little bit more difficult, right? So I think that there are markers that we can look at to use as guides, but a lot of it's going to be just being sensible.
And there's this telomerase phenomena.
Yeah, telomeres were huge, right? For a while, that was the answer, is that we knew that our telomeres got shorter. As we age, if we kept telomeres from getting shorter, then we would be fine. And again, way too simple on that as well. That's been really disproven that telomeres, that we can't really measure telomeres in every cell, right? So when we measured these telomere lengths, remember there was the test that was very popular for a long time of measuring telomere length, that we didn't know what we were measuring. What cell line were you measuring? Because telomeres are different in my, liver cells than they are in my kidney cells and they are in my lung cells. So all those telomeres are aging at different levels. So it wasn't really helpful to get this sort of generalized telomere length. And we realized too that may be, again, a very temporary phenomena to things as opposed to a really long-term picture. So telomeres are part of the story, but like I said, everything has to play a little bit of a role. And I think, again, to try and go after telomeres as the answer is way too simplistic.
Thank you for these myths, because many people like me, what did you say? Biohacker Syndrome. I like that. Dr. Yurth, I know that one of your expertise is in bones, obviously, not only the main expertise. And with that said, you changed my life in the process of changing, let's say, about osteoporosis. And you know the story. I shared it many times. Nobody bothered to tell me when I had osteopenia. When I asked them why not, and they were like, well, what could we do? Because, you're healthy eating, you're taking hormones, you're working out, there's nothing to do. Then here we are with a newborn osteoporosis. And then you were like very straightforward. He says like, you know what? You would break your bones. It's a tough one. And so many women that I know are struggling with it.
It's a huge problem. I'm so happy you brought it up, because I think it's really ignored even by longevity doctors, right? Like most longevity doctors I know aren't looking at women's bone density when they walk. And they're, you might be doing these fancy biologic age tests and nobody's looked at a bone density, which is, probably going to kill you before your biologic age would tell you it is. I think it's not sexy, right? Osteoporosis, it's like,
old person disease.
Look at it. It's not really going to kill you. It only affects elderly women. So I think that, and we don't really connect it to mortality, right? So we don't really think about it as the thing that's going to kill us. And honestly, it's a huge killer. So when you look at a single fracture, a hip fracture is a 30% 1-year mortality, 30%. 3 out of every 10 women and men who get a hip fracture will die within the year after that hip fracture. And that's huge, right? There's not a lot of diseases that have that kind of mortality, and we're ignoring it. Every time you have a vertebral fracture, and I see women who fracture their vertebrae bending over to make their beds. That's how fragile their bones are. I see it all the time. So every time you have a vertebral fracture, it's taking 5 years off your life. When you look at not just the death, but the loss of quality of life, once you fractured something, getting back to the same mobility, 80% of people do not get back to the same level of mobility they had after a fracture. And so we need to be looking at this disease much more seriously. And it should be included in everybody's regimen. Is you should have a bone density study, and know what your bone density is. And remember, your maximum bone density is in your 20s. It starts dropping after that. So really, when you're starting this venture around 40, maybe you need to have a bone density study and see if it's already low. So, and there's so many things that we can do for it, right? So the theory that we can't do anything short of, obviously hormones are huge. So first thing you do is go after hormones, go after all the nutrients that potentially are involved, vitamin D, K, magnesium, selenium, all really critical to bone health. But there's also actually really quite good medications now. We used to have just the old bisphosphonates, which were horrible drugs, like Fosamax, which are horrible drugs, still used a lot, but they basically create bad bone, abnormal bone, right? So they actually increase your risk of fracture, even though your bone density improves.
Wow.
But we have, things like Forteo, which is a parathyroid hormone. So it works the same way our body does to increase bone. It's a very safe drug that works very well. We can, use anabolics sometimes. So even short courses of bursts of steroids to help women heal from fractures, to help improve bone density. So there's tons that we can do, but you have to know that the disease is there, and this is a disease, and you have to know early. Because, like I said, you're going to sit there and watch somebody with osteopenia, and then when it's finally osteoporosis, you're going to do something. That's the wrong approach. It's like saying, I'm not going to treat your heart disease until you have a heart attack. So it should be in everybody's screening tools that they should know. And I'm saying earlier rather than later, what your bone density is, and follow it on a regular basis like you do all the other parameters. I will tell you that I see a lot of patients who have come from other doctors. Almost none of them come with bone health studies. So that's got to be a big part of your longevity regimen, because this will kill you and it will debilitate you, maybe more so than your metabolic health will.
Dr. Yurth, then I'm going to ask you something, because hormones help, but you start having the hormones under normal conditions. It's very rare that I hear that people start using hormones at their perimenopausal stage. It's mostly when you're kind of very, very close to your menopause.
Right.
But by then, I can only calculate with myself. I started estrogen with menopause. I started progesterone before that. And, around the same exact time, I had the osteoporosis. That shows me that it started somewhere around my 40s, early 40s, maybe.
Probably younger, yeah, probably in your 30s even, right?
Okay.
Max bone density is 20, 25. That's when your max bone density, it starts to decline after that. Some women, let's say you had an eating disorder, or you just were, you were always dieting when you were younger. Look at all the young women who are dieting constantly, right? Then likely you never reached a maximum good bone density So if I were to measure you at 25, you wouldn't even have optimal bone density, right? So number one, we need to encourage young people. We've got to get this out of, I've got one of my 21-year-old daughter who's very social media influenced, right? And everybody's skinny, and so we really have to sort of get that into people's heads that you have to start this process of longevity needs to start in our 20s. Not our 40s, but our 20s. So we need to start educating that. And are you going to do bone density study on all these women? No. But if I have a woman who has a stress fracture, or a man who has a stress fracture in their 20s, damn well going to get their bone density studies test. That doesn't happen, right? So you're a runner and you get a stress fracture. You think I ran too much. No, probably your bone density is not good. So we have to start that education early. And then really be aware of if there's a family history, for instance, or if that person is very thin and frail and does not have a lot of bone, or if they've been a chronic dieter, then do a bone density early. Do it before, like somebody like you who's thin-built and, blonde, you have higher risk factors. I don't know if you have a family history, but
we do. Like, my mom, my aunt.
So right there, you probably should have been addressed. At 30, we start looking at your bone density and we start saying, what do we need to do, early on to help you? Maybe it was more protein, maybe it was optimizing vitamins more, maybe it was more weight bearing, load bearing exercises, but that needs to start early. And so we have to have that awareness. Again, longevity needs to be starting in our 20s. And so I have 5 kids. It's one of the things I'm passionate about is we actually get this stuff that we're talking about instead of to the menopausal women, we get it to the 20-year-olds too, because that's going to make the biggest change.
You also send me a note about bone is an endocrine organ.
Right. That's the other thing we forget, right? Is that bone actually makes a whole lot of really important things. So it's not just, so when you look at bone, it is not just this benign thing that's holding us up. Bone actually releases growth factors that help muscle, and then muscle release growth factors that help bone. So they actually play back and forth. So when you start losing bone, you actually are releasing less growth factors that are helping in other ways, what we call paracrine influence. The bone is affecting other organs, right? We don't think of the bone as an organ, and it is. It is producing a lot of growth factors and chemokines and cytokines that are useful for other parts of the body. So when it's thin and not doing that, other parts of the body fail, including muscle.
Yeah, so basically osteoporosis and sarcopenia kind of goes hand in hand.
Parallel, exactly. Bone affects muscle, muscle affects bone. So if we don't have enough muscle, our bones will thin. If we don't have enough bone, our muscles will start to fail. They play back and forth with each other. So they're sending off these, and it kind of makes sense, right? My muscles, if I have more muscle, I know my bone needs to be denser. My body knows that. It knows that I need thicker bones to support the muscle. So the muscle sends out a message, you need to get denser bone, right? And the same thing, when my bone is denser, then my body's going to say, oh, I need more muscle to support this denser bone. So it sends out messages, paracrine messages to the muscle to get stronger. So, it's a perfect system. It's just that we let it fail.
Yeah. So let's now go to that fun part, because I have all these notes. Let's start with NAD, because I know your thoughts, and it's a craziness everywhere in the world and in Turkey. Like, number one treatment that is pushed to people here in Turkey is IV NAD. Like, it's the solution to everything. And now I started telling people, no, it's not that great. And they're like, oh, maybe I'm doing every week, like 1,000 milligram of NAD.
Doing a lot of NAD, yeah. Again, here's another fallacy. Just because something is lowering in our system as we age is putting more back in the right answer. We know NAD levels drop as we age. We also know NAD is absolutely critical to life, right? That is how we make ATP. It's how we make energy. So sensibly, we go, okay, well, NAD levels drop as we age. NAD is critical. Let's put more NAD back into the system, okay? And this is, again, like this whole antioxidant thing I was talking about. So we have to look at why NAD is decreasing. So the reason NAD is decreasing largely as we age has to do less with us making less NAD and more with that we are depleting NAD more rapidly. And that's really due to a couple of enzymes, particularly one called CD38 and another one called NNMT. And so as we age, or if we're sick, or if we have cancer, or if we have metabolic disease, or if we're obese, then we have higher levels of these degradative enzymes, right? That's why sicker people have less NAD. They're depleting it, okay? So these enzymes, so picture you've got this bucket, and you keep filling this bucket, but it's got a hole in it, and that hole is leaking, and it's spilling out stuff all over your nice wood floor. So people keep filling this NAD bucket. They keep getting more and more NAD, and they feel great, but they don't know what's happening underneath, which is that we're degrading that NAD very rapidly, and the degradative the things that are produced in degradation are doing some bad things. One is something called 4-pyridone. So as that NAD is degraded down, we have too much of it, right? It's coming out of the hole in the bucket, and it converts into something called 4-pyridone. 4-pyridone is very linked to cardiovascular disease, very linked to cancer. So now we're feeding a byproduct, by giving more NAD, a byproduct that's actually doing harm. So what we really need to focus on is the mechanism of why these things are changing. So instead of just filling my NAD bucket, which albeit is important to have a full NAD bucket, I need to plug the hole. So I could use things like something called 1-methylnicotinic acid, 1-MNA, which is the body's way of turning off this one of the enzymes that's degrading it, right? So it goes back, it's a feedback loop. So we can give some of that to block that, and you can use something called apigenin to block CD38. Now I've filled the holes, and then periodically I can put a little NAD into the system. I can do maybe, once a month or whatever, once every 6 months, a little NAD. One of the problems is we really can't measure NAD inside the mitochondria, which is where it's important. So there are these people who are measuring NAD, and you can measure cytoplasmic NAD, but the cytoplasmic ratios of NAD are very different than the mitochondrial ratios. So we really aren't measuring the thing we need to know. So measurements are probably silly and not really useful. So honestly, we have to just, again, look at what happens to the system as we age, try and put it back, and try and make it adaptable. The best way to do that is to do the way the body does, which is to get rid of these enzymes that are doing the damage and let the bucket refill itself naturally with things like exercise, healthy diet, sleep, all those things that are keep NAD. I think NAD should be used periodically, like if I've been sick, or I just had a really stressful period, or I went through I ran a marathon, I just got over COVID. Then fill your NAD bucket, but at the same time, block those enzymes. So I never would use NAD, and I think the better thing is to use a precursor like NMN, but I would use NMN along with apigenin and 1-MNA, and I would do it for a short period of time. And then I just stay on a little apigenin and 1-MNA pretty continuously to keep my bucket full, because I know those enzymes are elevated as I age. I'm going to keep them lower. So I think that's where we've got to stop looking at, if something's good, let's put more back into the system. It's not the way our body works.
So the molecule of NAD is pretty big. So does it get into the cells when you do the IV?
So really, it has to be broken down into nicotinamide primarily. So really giving nicotinamide is probably the cheapest way to get NAD levels up, is to use nicotinamide. NMN, they just recently did find that NMN does have, we used to think it couldn't get absorbed directly into the cell, it had to be broken down, but we did just find that it does have a receptor. So NMN does appear to have a receptor that can get it into the cell. NAD has to be broken down to get into the cell. So why aren't you just using the things that's broken down into, which makes more sense and is usually less expensive? Now, NAD will get there. It's getting there by breaking down into these precursors. Why don't you just use the precursors instead?
Yeah. I know that you're a fan of GLP-1 agonists.
Huge fan.
They may not understand from the peptide name, but let's say Ozempic, Mounjaro, and there's a new one, I guess.
Right.
There's obviously debate out there. There are doctors that are very, very against. And then there are people like you, JJ Virgin, and a bunch of other people that are really for. I know that lately there are researches that are showing it's more than curbing the appetite. But can you share, where did it come from? Because I know there's a history of these GLP-1s.
We've been using GLP-1s for a long time, before they ever became really huge for weight loss. We were using them in low dose as anti-aging drugs, basically as longevity drugs. And the reason is because they are so protective to every organ system. So we know that there are GLP-1 receptors on your liver, on your immune cells, on your heart, on your brain. So there are GLP-1 receptors almost on every organ. So basically, we would use GLP-1s at a lower dose, way back when we just had oral ones like liraglutide, at a low dose to help us with people with heart failure, for instance, or for dementias, because we know the mechanism, which is when you upregulate GLP-1 activity, you have protective effects on the heart, on the brain, on the immune system. So if you understand what the GLP-1s are, now the other place they work is on the brain to decrease appetite and to help the body get rid of fat. So very interestingly, even if you don't eat less with GLP-1s, you will lose some of your white fat. They have that mechanism. And that's because there's GLP-1 receptors on fat cells. So basically, if you know what you're doing with a drug, if you know the mechanism, then you know what you can use it for, right? So we were using these long before they became huge for weight loss. Now, it took a higher dose to get them to the weight loss benefits. So, and so what you could do is use these high doses for weight loss. But when I want these multi-system benefits, which is reducing systemic inflammation, cardiovascular protection, neuroprotective effects. They're in phase 4 trials for cognitive decline.
How does it work to the brain? Because I know that they're working on Alzheimer's and Parkinson's disease, I guess.
Right. So because of these GLP receptors on neurons, it actually improves neural function.
Okay.
They also have, we talked about the other factors of aging. So like getting rid of senescent cells. We know that you get rid of senescent cells with GLP-1s. We reduce oxidative stress with GLP-1s. But again, in a homeostatic fashion, that's a nice thing. Instead of using an antioxidant, I'm using something that controls, doesn't blunt, but controls oxidative stress, which is a much better thing. We call a homeostatic mechanism. It doesn't go overboard. It just says, oh, I've got too much oxidative stress, I'm going to bring it down. Oh, there's too little oxidative stress, I'm going to let it go up. So these homeostatic drugs are actually hugely beneficial. So low dose, you get rid of the side effects, which are, primarily the gut side effects of these drugs. You don't have the weight loss, ongoing weight loss. You don't have the, the constipation risks or things like that. You get all these other health benefits. So I think, honestly, they may be one of the best longevity drugs that we have because you look at all of the things that they're doing, right? Now, where they've gotten their bad rap is using the higher doses that we need for things like weight loss. And the things you're going to hear there are all these people are losing all their muscle, right? Or the Ozempic face, losing all the fat in your face. Ozempic face, yes, when you lose a lot of fat, your face will get skinnier. People who are thinner have more saggy faces, right? Fatter people have their faces plumped out with fat. That's why we put fat into the face. So basically, yes, that's just a weight loss thing. The muscle loss is a misnomer. In fact, GLP-1 agonists, when they came out for diabetes, were to help maintain muscle in diabetes because they would actually move glucose into the muscle.
Wow.
So basically, the only reason people lose muscle when they are on these drugs is because they do not eat. So if you can push protein first, so people are always eating enough protein, you actually put on muscle and you lose fat. So that is, again, that's a complete myth that has to do with the fact that people stop eating. So we monitor our patients. We say, listen, you've got to be eating, 120 grams of protein, even though you're not hungry. That has to be the first thing you're doing is filling yourself with protein. But it's hard because you're not hungry, right? Sometimes you have to adjust the dose a little bit. The other thing is when you look at the GI effects, right? People are saying, oh, they have all these horrible GI effects. That's when people push the doses up too high or too fast, then they're going to get GI complications. Used sensibly, appropriately, titrated appropriately, I see very rarely do I have any complications with these drugs, even at the higher doses that I'm using for weight loss.
Mm-hmm.
But I really want people to know how valuable these drugs are for heart disease, for brain disease. I think if you have early cognitive decline, if you have congestive heart failure, or you just don't have great cardiac function, these are drugs you should be on. Right. I think that or immune dysfunctions, autoimmune diseases, they can be very helpful for. So I really think you've got to be careful with saying these drugs are bad based on these high doses that people are overdoing and getting side effects from.
Dr. Yurth, I have a question. Yeah, low dose can be, I think, compounding pharmacies and peptide version. But if people don't have access to them, is it dangerous to stay on whatever in the lower end of the regular brand names?
You can get Ozempic and just use it as lower dose. The problem is the injectors are designed to have a certain dose, but you take the lowest dose, do it once a week, and that's usually fine.
So there's no any side effect if you pay attention to your what you eat and your exercise.
Exactly. You've just got to make sure that you're eating despite the fact that you don't have an appetite, right? So I always tell my patients, you're going to have to forego the other stuff and always eat your protein. And if we see people stopping, losing muscle, monitor them, we stop the drugs because we're like, you are not eating enough protein. We will not give you back this drug until you eat enough protein.
J.J. Virgil said that if I was a good dictator, that I would say, like, I would only give you the drug if you eat the protein and do the weightlifting. Otherwise, I wouldn't give it to you.
Right.
Let's now jump into this cholesterol matter. You don't need to give too much detail, but, I came to you and I was like, people freaked out of my high cholesterol. LDL was like 172. Oh, don't eat red meat. Don't do this. Don't do that. And then there's huge fights over here as well. There's actually a doctor who's almost banned out of things that she says, like, cholesterol is not bad. Like there's all type of mixed messages. And I see lately, what interesting, actually, I know that you put in your notes, in certain blood work that I ask my patients to do, I see low cholesterol, like below the normal range.
Right.
Lately, I started seeing that.
Right, which is a really bad thing. And typically means the body is in a failure state when you start seeing cholesterol levels drop.
Wow.
Like you'll see that in cancer patients, right? That their cholesterol levels will start dropping, not just even if they're eating. So there's so many myths about cholesterol, Ezra. And you could do a whole podcast.
In a nutshell.
So in a nutshell, here's the two biggest myths. Number one, you need cholesterol. You need it for hormone production. 25% of the brain's dry weight is cholesterol. It's essential for nerve function, neurotransmitter function. Myelin. So, when cholesterol starts to get lower, you'll see people's reflexes decrease. You'll see them have more numbness and tingling in their extremities. You'll see more cognitive decline. If cholesterol gets less than 140, we start to see cognitive decline. We start to see brain shrinkage. In fact, Dr. Goodnow did a study looking at cholesterol levels and functional MRIs of the brain. And the brain's volume was completely parallel with cholesterol. Higher cholesterol, bigger brains. Lower cholesterol, smaller brain volume. Brain was shrinking when people had lower cholesterol. And yet we have these doctors who are pushing cholesterol down to ridiculously low levels. In an optimal level for brain health is probably somewhere between about 190 and 250. So it's much higher than what we think is a healthy level. Second big myth is that you can make a big change in cholesterol by what you're eating. 10, maybe 20% of cholesterol comes from our diet. The rest is what our cells are making. So our body makes cholesterol. So our peroxisomes make cholesterol. So basically, when our body's in a stress state, sometimes it'll stop that production. That's why you'll start to see cholesterol levels drop. Or if the peroxisomes are not functioning well, we'll see cholesterol levels too high or too low. So it comes back to these cellular mechanisms that we have to look at what's going on at the cell level, not just say, eat less fat. And then the third thing is really this oversimplification about cholesterol, that we have LDL's bad and HDL is good. That's not so. LDL isn't just bad. There's actually really good LDLs. It really depends on the particle size and the type of cholesterol. So it's not LDL. In fact, is super protective from infections. It's so people who have lower LDLs have more infections. They die at an earlier state. We know that LDL is actually a good thing, but you have to have the right type. So you have to look at instead what are called apolipoproteins. And apolipoprotein B, think of it as, really taking all the small, dense, more dangerous particles, and apolipoprotein A as the good particles. And that ratio is by far what's the most important thing. So that B to A ratio is by far the most valuable thing. We see people, and I see doctors and I see podcasters talking about pushing ApoB down to 45. I will tell you, if you have an ApoB of 45, your likelihood of dying of an infection, if you get sick from a virus or a bacterial infection, goes up about 10-fold. So we know that, again, nothing in the body is all good or all bad. It's just not the way our body is made. So our goal is to have this balance of the apolipoprotein Bs. We want some, we don't want too much. We want it balanced with these good cholesterols, the transport mechanisms that are taking it back. I always like to think about, cholesterol is being transported out of the liver it's carried by the ApoB. So cholesterol is a fat, it can't move through water, which is blood. So it sits on ApoB. ApoB carries it. It drops it off everywhere it needs to go. And this is simplistic, but then think about now there's too much, it's going to just drop it off in the arteries. ApoA is a little guy who's coming up to clean up. It's like, oh, too much cholesterol here, I'm going to clean it up. I'm going to take it back to the liver and recycle it. So if I have a good level of ApoA to recycle that bad cholesterol, then I do fine. So we really want to look at that ratio. And then we want to look at, things like whether the person genetically has what's called Lp(a). Lp(a) sits on the ApoB, makes it denser and heavier. So those people, you have to push the ApoB ratio down a little bit more, get it down to like a 0.5 level. So there's a lot of things to look at here. The big key is, number one, diet is not a big, huge player here. Keep eating your good fats, please. Keep eating your meat, please. It's really important to your brain. Number two, you do want a good level of cholesterol. I would say 170 to 250. It's going to depend on my person where I put it into that range. If you get less than 140, you're doing damage. Then you should know your ApoB and your ApoA. You should know that ratio. You should know what your Lp(a) is. And then we personalize things, right? We can do scans, see if there's even a risk factor to that person.
Doctor, I know that you use a lot of second-purpose drugs, like, let's say Rapamycin, Naltrexone, whatnot. Let me first ask about the Rapamycin, because lately Brian Johnson coming out with like, oh, this is doing nothing, and he stopped. And I heard like a bunch of people, including my sister, saying like, oh, he said that it's not doing anything, and she stopped.
So number one, Brian's looking at very, minimal short-term data. And recently, I can't remember what other drug he decided wasn't working for him. I can't remember what it was, because it was the GLP-1s. Mm-hmm. He put a big thing where the GLP-1s weren't working for him because his heart rate increased by 3 beats. And so that's obviously bad. His heart rate increased by 6. Yes, we know that GLP-1s do increase heart rate. We think that the benefits that they carry far outweigh a 3-beat increase in heart rate. So, Brian has so focused on little things that he's not seeing the forest through the trees, that there's bigger things that are going on that you can't measure so easily, right? And when you look at drugs like Rapamycin, when you look at its mechanism, you're probably not going to be able to see things very short term. It's probably going to be a very long-term influence. And that's why it's hard, right? It is hard for us to know. We have to base it mostly on our animal studies because we live too long. We don't know yet, right? We can, because markers may be changing subtly, but what's going on in the big picture is taking longer. So when you look at the mechanisms of things like Rapamycin, we know that by periodically slowing down mTOR, mammalian target of Rapamycin, that we will extend life. That's been well proven, right? So in animal models, we know that Rapamycin is one of the best drugs for blocking mTOR. So if I stop it and start it, I do it for a day, I stop it for a week, I do it for a day, I stop it for a week, I can actually turn off and on mTOR. And in theory, that should, over a long period of time, extend my lifespan. At least it does in animal models, right? We're basing a lot on animal models. And yes, rats are not humans. Maybe we're different. But I have to look at cellular mechanisms. From a cellular mechanism perspective, it makes sense. So it's a drug that I still include in my regimen. I think it makes sense. Can I be certain? Will I change my mind in 10 years? Maybe.
What are the other second-purpose drugs that excite you? Because you use quite a bit.
I use a lot of repurposed drugs, yeah. I love repurposed drugs because for those of you listening, repurposed drugs are drugs that have already been FDA approved. They're safe. They've been shown to be safe and effective for a certain purpose, right? So basically, when the drug gets approval, it gets approval for one purpose, because that's the easiest way to get approval for a drug. I have a drug that is an antibiotic for this bacteria, or a blood pressure medicine for high blood pressure. So, but when you understand mechanisms of drugs, you can see how many other places they can be used. We talked about the GLP-1 agonists, same thing, right? Yes, they're great for diabetes. But when we looked at GLP-1 receptors all over the body, we said, oh, these have a lot of other benefits. A couple of my other favorites. So Telmisartan. Telmisartan is a blood pressure medicine. So FDA approved. It's been around a long time. It's been shown safe. It's been shown effective to lower blood pressure. But if you look at it as a tool, it's one of the few things that activates something called PPAR gamma. PPAR gamma is, think about it as like a power plant for your mitochondria. It makes your mitochondria rev up. Telmisartan is a banned drug in the athletic foundations because it does improve mitochondrial function to such a degree that you will see an increase in performance. But it's also been shown to be protective for brain cells, mitochondrial, energy management. It's maybe one of the cheapest, easiest longevity tools out there. And you can use it at a dose that doesn't affect blood pressure. So if I'm using it at 80 milligrams, maybe my blood pressure gets too low, but I can use it at 20 milligrams to get these other effects, to enhance my mitochondrial function, to improve my energy, to protect my brain, to control endothelial function in my blood vessels, which is really important to cardiovascular longevity. So I love Telmisartan because it's an inexpensive drug. In fact, I played a game with AI, and I said, out of all the drugs you can think of that are out there, that are already approved, tell me the one drug you would come up with that would actually be a great longevity tool based on safety, cost, and efficacy. And it came up with Telmisartan, which I found interesting because I love that drug. So, so I think it's an underutilized and overlooked drug. I don't ever hear doctors talking about it, and I use it in my practice a lot.
Am I using it? And that's what I was going to come with that question. I don't think that I'm taking it.
I'm not sure you're on that one.
Not yet.
Cialis or Tadalafil is another one.
Mm-hmm.
Think about Tadalafil. What is it used for? Primarily, it's what's called phosphodiesterase 5 inhibitor. It's used for erectile dysfunction. But what else do phosphodiesterase 5 inhibitors do? They have so many other benefits in longevity. So when you look at the phosphodiesterase 5 inhibitors, it's really good for blood vessel function, right? That's why they improve erectile function. Where else is good blood flow helpful? How about the brain? So it's been well shown that guys who are taking Cialis regularly get much less dementia.
So it's same as Viagra, yeah?
Yeah, same as Viagra. Viagra and Cialis, same drugs, right? So basically, you can use these, the phosphodiesterase inhibitors, again, super safe at a very low dose, right? We don't need to use a dose that's causing erection. We use a low dose. I use it in women and men, right? My women are on 2.5 or 5 milligrams of rapamycin just as often as my men, because we know that that's going to improve their brain function. It's going to improve their blood vessel function, right? If I improve blood vessel function, all my organs are going to work better. My kidneys are going to work better. My liver is going to work better. I'm going to have better muscle function. So phosphodiesterase 5 inhibitors have, and they've also been shown to have some nice anti-cancer properties, as does Telmisartan. So they're an easy, again, inexpensive, easy tool, low side effect profile, not at all costly, easy to obtain. So I love those as drugs too.
What do you think of this metformin at some point was so popular?
I used to use metformin all the time, right? So it was one of our go-to longevity drugs. And I do think it has longevity benefits, right? It is an mTOR inhibitor, much like rapamycin. The problem is that some of the more recent research that came out on metformin showed that it probably impaired muscle adaptation to exercise, particularly as we aged. So maybe in younger people, it wasn't such a problem. But as we get older, it appears to impede muscles' ability to get stronger with more force. So that concerns me because, I don't want to be frail, right? I want good muscle mass. So it concerns me to have a drug that, yes, probably does have some positive effects on longevity, but is affecting my muscle mass concerns me. We also know that it does have a negative effect on mitochondrial function. So that's the other thing, right? Where are mitochondria important? My heart, my brain, those are the most mitochondrial dense tissues. So could we over a long time be having adverse effects because of its mechanisms, right? So again, going back to mechanisms, I always am looking at mechanisms. The biggest trial that was done on metformin was called the MILES trial. It had pretty mixed results, really, regarding longevity. And I think that's because of its adverse effects in some of these other places like muscle health and mitochondrial function. So I've taken it out of my regimen for patients. I think we have better options, especially with the GLP-1s.
Dr. Yurth, what do you think of resveratrol?
So I think resveratrol has some value microdose at a very low dose. I do think it has some value as a longevity drug as a microdose, used off and on. But the data is not at all panned out on the doses that people are taking of it. It probably has negative, because it's a very potent antioxidant, it probably has negative effects on having blunting oxidative stress too much. It's really been pretty disproven as a really good longevity tool. But I do think microdosed, and I'm talking about really tiny doses, like 25 milligrams, there may be some benefits to resveratrol in terms of some like arterial function and things.
Yeah, I don't think that exists at that low dose.
No, you have to get a compound at that low dose.
What would be if you choose one thing? The bonus question. One thing that is going to be affecting all part of our system. One longevity intervention.
I honestly think the GLP-1s are going to be, if you look at every organ system, every one, and those are the most important ones, our heart and our brain. The GLP-1s at a low dose, especially the third generation, which is called retatrutide, which is a triple agonist, I think these are going to be probably the mainstay. If microdosing those on a regular basis is going to be one of the mainstay drugs that we can utilize for longevity. I really do.
But second to the best, I know that you suggest that it's workout?
Exercise.
Exercise.
Trick question. Yep. By far, you can do one thing, exercise, right? Exercise affects, it does all those same things that all those drugs we talked about did, but it's cheap. It releases all those growth factors to support your bones, to support your muscles, to support your brain function. It is the only pill right now that we know has zero side effects, right? I guess you can over-exercise and hurt yourself, but zero side effects and affects every organ system positively. I mean, and we now know you don't have to go out. I mean, I just saw some podcaster who was interviewing somebody who says she lifts weights for 2 hours a day. And you don't need to lift weights 2 hours a day, right? You need to be doing something every day. You need resistance training. It's critical. So you have to make sure you are doing resistance training. That means lifting weights. And you need to be doing, like after meals, you should be walking. You should be getting your steps in. But in general, if you can at least 5-6 days a week, do some exercise with at least 3 of those being resistance training and one of those being a zone 2 training day, then your longevity benefits are going to be, your likelihood of getting dementia, your likelihood of getting cancer, your likelihood of becoming frail are all going to be diminished markedly.
5 days. Yeah, I think I will be looking like a huge muscled person.
Yeah, I mean, you put on muscle. You put on muscle. Those you guys who don't know, Ezra puts on muscle.
I was gonna wear a tank top, and I said I don't want to scare people. Since I just finished my 6 weeks of nandrolone thing, I'm back on being like this.
Yeah.
This.
Probably you don't need to lift as heavy weights. Like for me, I have to lift heavy weights to put on muscle. It's much harder for me to put on muscle than you. You can lift lighter weights, but you still got to do that bone loading, especially for you with your bones, right?
Dr. Yurth, one last question. I know that your time is very limited. Actually, it was my producer's question. It's also like NAD, glutathione IV is very much constantly suggested, almost pushed. How do you feel about that? We had Nayan Patel in the past in my podcast, and he had his own thoughts. The IV.
We know that glutathione is the master antioxidant, right? I mean, it is really important as a detoxifying agent. So we absolutely need high levels of glutathione, especially because we're exposed to so many toxins. Environmental toxins are rampant. You can't get away from them. And glutathione is one of our main detox systems to get rid of them. But remember, when you give IV glutathione, it actually doesn't get into the cell until it gets broken down. So that's actually get broken down into cysteine, and then it gets back to the cell where it rejoins and makes glutathione. So there's nothing wrong with it. It's just an expensive way of getting glutathione inside the cell, whereas it's a little bit like the NAD we were talking about, whereas instead just giving an acetylcysteine, which goes into the cell and converts into glutathione, because you're doing the same thing. When you give glutathione, it has to break down into cysteine. So let's just give the precursor instead, because it's much less expensive and easier to do. But if you want to spend the money, there's nothing wrong with it. It's just an expensive way of getting glutathione to the cells.
Dr. Yurth, I can ask you so many questions, but thank you so much. I mean, you're a wealth of information, and I really appreciate you very much. So
I appreciate you too, Ezra. Thank you for being out there, spreading the word, and being sensible and stuff, and teaching people. I mean, it's such a valuable resource to have people like you out there. So,
Dr. Yurth, where can people follow you? Because I know that you're big on educating people.
Yeah, it's probably my biggest thing, you guys, is I think you've got to learn this stuff because there's a lot of information out there. You have to be able to learn and understand and figure out what's good information, what's bad information. So we have an education, it's called Human Optimization Academy, where we try and teach from research literature. We try and help you understand how to read your own labs, what little factors in your labs you should be looking at to say, what is my immune function doing? What is my cell health doing? So Human Optimization Academy, you can join, you can do courses on there to learn to read your own labs, to, understand even little subtleties and a complete blood count that your doctor might not explain to you. And then we do these Q&As every month that are kind of like this. We rapid fire, just talk about a whole bunch of different stuff that people want to talk about. But I try and base it all off the most recent scientific literature. So join Human Optimization Academy if you go to BLI.academy. Our institute's called Boulder Longevity Institute, so love seeing people there. If you go to just Boulder Longevity Institute.com, BLI.com, and you can find information on that. But and then follow me at Dr. Yurth, and for any podcasts I'm doing or things like that, those will usually be posted there. But I really encourage you guys to keep learning. I love educators like Ezra out there doing this. Try and educate yourself as much as you can, because you're not going to rely on the practitioners to do it. And, a lot of the people who are out there preaching things have something to sell, right? So you have to be careful on what you're listening to and how you discern that knowledge.
Thank you so much.
Thank you, Ezra.